Patterson. And we'll have to say, yes, we know that. Okay. Jennifer has a Bachelor of Science and also a Master of Science in Physical Therapy from Grand Valley State. And for the last 21 years, she has worked for Spectrum Health Rehab Services. She took her specialized training from the Wallace Pelvic Rehab Institute. And since 2006, she's been treating patients with pelvic floor issues at Spectrum. She's also an AFAA licensed group exercise instructor and has been teaching for gulp almost 30 years. Obviously, she started at age 2.
Obviously, totally, yeah.
I think it was 3 years ago that I was having some issues and my doctor referred me out to Spectrum's Physical Therapy Center in Granville, is it, or Wyoming?
Technically it's Wyoming, but yeah.
Yeah, anyway. And I first met Jennifer and it took about 15 minutes to figure out this woman is a born teacher. And I wanted to be sure that we could share her with all of you. So with no further ado, we will do that. Word about questions. Jennifer is happy to receive questions during the presentation. And if you will please wait for me to get to you with the microphone so that everyone can hear, and then Jennifer will repeat the question. There will also be a Q&A session at the end. Here's Jennifer.
Okay, let's get this on. I'm used to wearing these in all my group exercise classes, so they trained me for something. Hair in the way doesn't help either, though. All right. Does anybody know if this is picking me up okay? Yeah,
It
awesome.
sounds great at home.
Okay, I'm going to just clip it to me then. All right. Yeah, and I say something on a little personal note too. So I have, I've been in the Grand Rapids area. I transferred to Grand Valley in '94, winter of '94. And I don't know if anybody remembers the snowstorm in January of '94. Yeah, I grew up in East Lansing and my family's from Detroit. I had never seen that much snow ever. I thought it was some like fluke phenomenon. I was taking pictures of it. Like it was something we were never going to see again. And then I quickly realized this is just West Michigan and it snows a lot here. So I met my husband at Grand Valley. We've been married for 21 years. I have 2 daughters. One's a freshman in college and one's a senior. So it's been a crazy last couple of years with COVID of doing college visits, not doing college visits, not being able to, trying to figure out where they're going to land. So it's been a crazy couple of years, right, for everyone. So yeah, they're good. Love my kids. Oh, and I have a 4-year-old boxer who's like the love of my life. So she gives me lots of love and snuggles. All right. So today's topic is pelvic floor, physical therapy. So a couple years ago, I did present and we talked a lot about bladder, and I'm going to touch on some of that today, but then we kind of felt like, hey, let's tack on some new information today and let's talk about some bowel health, because who doesn't want to talk about bowel health, right? All right, so let's talk about pelvic floor and what it does. So your pelvic floor is a group of muscles that basically line the entire rim of your pelvis structure. So it sits in there like a hammock, like a little trampoline system. There are 3 layers of muscle, and then every layer has multiple muscles within it. There's a ton of muscles in this group, and people just don't think about their pelvic floor very often because we don't have to. The luxury of that is it's on autopilot. It usually does what it's supposed to do throughout our life, and it is until something's kind of going wrong that we kind of pay attention to it. To me, I tell people it's like breathing, right? Like you can breathe, you don't think about breathing, but can you change your breath? Can you affect it? Can you slow it down, speed it up? Yeah, so you can kind of flip from autopilot to manual, and you can do the same thing in your pelvic floor. It's usually on autopilot, but we can flip it to manual and have that control. So it does a lot of different jobs. It's our support system. So kind of like the bottom of a grocery bag, holds all our organs up, which are our groceries. So we got that support. It works to control bowel bladder. So it's another line of defense in keeping us continent and also allowing things to exit our body. Has a role in sexual health, stabilizing. It's actually part of your core. So when people talk about core and they're only talking about abdominals, they're not really doing the core system justice, and they're kind of missing 50% of what should be happening, which is your pelvic floor. Works with your abdominals and your back and your hip muscles to help stabilize that whole area. And then it actually does a little sump pump action throughout the day for our lymphatics to help move fluid throughout that area of the body. So even as you're sitting there breathing right now, your organs are moving, your your pelvic floor is moving and you just don't even know it. Your kidneys move up and down with every breath. Your pelvic floor has this little pumping action. So lots of things going on, again, that we're just not even aware of that are happening from a minute to minute basis. So this is, I'm gonna use my little cursor here. So if we're looking sideways, and this is a female anatomy picture. So we've got spine, so backside, just to get you oriented, front side, pubic bone there. Here's the bladder. Person still got a uterus and then a rectum. So you can kind of see this little sling underneath there. That would be pelvic floor. So I love anatomy. I'm not going to go into detail, but it just gives you some perspective of the complexity of this area. And this isn't even, it doesn't even show nerves, no vasculature, nothing like that. Like we're just looking at some bone and muscles and some connective tissue right now. So it is a really complex area of the body. On the left, we've got female, and on the right, we've got male. And again, you can see how some of those muscles are running all different directions. They're slinging, kind of winging out in different areas. I always like that view. That's kind of an interesting view of how you can kind of see all those connections around the rim of the pelvis, even back through the sacrum and the coccyx throughout that whole space. External, outside. So if you were looking, somebody had a mirror underneath you and they could see up through your skin. Again, lots of different muscles running all different directions. So I could go into like a 3-hour lecture on anatomy. So we'll just keep moving. All right. So urinary tract. Basically, again, we mentioned kidneys. Those are going to be processing and making your urine, which is constantly producing urine. So again, even just sitting here, your body is constantly making it. It's dripping into your bladder like a leaky faucet. Okay. And then your bladder, which is just a balloon of muscle, it's just a liquid waste receptacle. That's its main job. That's what it does. It holds our liquid waste. So as those kidneys are making urine, dripping like a leaky faucet into that bladder, your bladder just expands. And when it feels that stretch of those muscle fibers, that's what usually gives us that urgency. Now, it doesn't always. Sometimes our bladder does misfire, and we'll talk about that in a little bit. And it tells you it has to go when it doesn't really have to go. So it kind of lies sometimes. Digestive system, a little bit longer in nature, a little bit more complex. So they really consider the digestive system from point of entry to point of exit. So including your mouth and all of those tubes your food has to go through your stomach. Small intestine is about 10 feet long. Large intestine is about 5 feet long. I mean, it has to go through a lot of piping in order to hit the exit. And along the way, then we've got all these enzymes that are helping digest it and absorb nutrients and reabsorb water after it's put water in. So it's a little bit more of a complex, long travel system here. What can go wrong, right? So again, we kind of go through life just not really having to think much about that area until somebody may start to experience some symptoms. So if I have an underactive bladder, pelvic floor, we'll get there, then things aren't going to be supporting me as well as they should. So that can lead to leakage of bowel or bladder, organ prolapse. Okay, organs can start to migrate out of their little home space and head southward. And that's basically a prolapse when you have things going towards the bottom and out of their connective tissue support center. Dysfunction, maybe I can't start a stream anymore. Maybe I've got such laxity that my bladder has dropped and now I've got a kink in my urethra and my bladder's trying really hard to contract, but now it's got to push urine out of like a kinked hose. Okay, think about like a garden hose. If you kink it, stuff isn't getting through very easily. So that support really comes into play with things like that, with prolapse. Pressure, heaviness, again, things are just sagging towards south if you don't have that good support system. Back pain. This is a big one that gets missed a lot of time. And I feel like the general population, especially for some younger women, when I think back to when I first started and I was like a little newbie PT and I would see, women for back pain, they felt great in the morning. And then as the day went on, or they were on their feet for longer periods of time, they would just start to ache and just kind of have this pressure, and they got better. I mean, we worked on our core, we did hip strengthening, back strengthening, abs, body mechanics, all that stuff. And they always felt better. But then after getting into pelvic floor and realizing, oh, that weakness in those support structures that were helping hold all those organs up that are attached to your back can lead to some of that back pain and achiness because things just start to drag and sag over the course of the day. So they wake up feeling great. And then by nighttime, they're, super painful. So back pain can be a symptom too of some lack of support. Obviously, pregnancy and postpartum. Pregnancy is just a lot of weight sitting on top of that pelvic floor for 10 months. And then those muscles have to expand to give birth. Our pelvic floor is actually very uniquely built. The muscle fibers can expand and lengthen 3.5 times their length before they start to tear and fail. Normal muscle can only do that 1.5 times its length. So it is built really amazingly to stretch and expand and allow that birthing process to happen. But we're not quite there in our society yet of thinking about rehabbing that afterwards, which a lot of countries in the rest of the world, if you give birth, it is part of your postnatal care. You are automatically sent to pelvic floor rehab to strengthen these muscles, to do prolapse prevention, to work on scar tissue, to get the core strengthened back up, body mechanics, so that they're not seeing these women 5-10 years down the road with leakage issues and pain, and now they're surgical because they prolapsed. And so we're not quite there yet. That in my working lifetime, if that could happen in America, that would be super. That would be like a dream of mine, is that everybody who gives birth just automatically goes to pelvic floor therapy for a couple visits. So overactive, you can have things too active, right? Think about like upper traps sometimes, right? Like those can just be a little too active and tense and tight. And maybe that's where somebody carries their stress or how they're positioning and posturing themselves throughout the day. Just like that can affect our mechanics of our neck and upper trap area, that same thing can happen in the pelvic floor. So if I've got something that's a little too restricted, a little too tight, a little overactive, then I'm not probably going to be able to relax very well and let things come out. So then I'm going to have difficulty maybe starting my stream, keeping a stream going, constipation, straining, painful intercourse. Again, back pain, just like things falling out. We don't think things too tight and not moving either. The other stuff on there is more of, there are just some diagnoses for like pain issues with the bladder and the pelvic floor. And then again, nerve. So there's lots of nerve bundles and things that travel through this space. So and one of them in particular the pudendal nerve takes a very tortuous path from our sacrum around through our sit bone. It goes out this little connective tissue around this little hook in our pelvis. And then it branches out. So there's a lot of places along its path that it can actually get restricted and kind of squeezed, and it doesn't glide real well. So you can end up with people having numbness, tingling, pain. Sometimes we'll see some of this from people that bike a lot and don't have a real well-fitted seat, because where your sit bone is, part of that nerve is. So people who spend a lot of time on spin bikes or road biking, that type of thing, they can end up pinching that nerve and giving themselves a saddle anesthesia, which is like when you've got some numbness kind of right in that saddle, as if you were like sitting on a horse. All right. Isn't that awful? I know, it makes me cringe, but it's the balance, right? So basically we've got to balance out that stability and mobility. We want things to be strong and mobile. And just because something is tight doesn't mean it's strong, right? You could have somebody that's 100 years old, that's bedridden, and they're super tight and not mobile. They're not strong. And then you could have somebody like her that's super flexible. She's definitely not weak, right? Like the stuff she can do is amazing. So I don't know about her balance. I worry about her prolapse issues down the road, but it gives you that idea of like, we have to have both. Okay. And just because something moves well doesn't mean one thing or another. And just because something's tight doesn't make it strong. So balance is key. Okay. So let's talk about pelvic floor therapy for just a second, kind of what we do and what we look for. It's the evaluation and treatment of all of these muscles and joints and connective tissues and nerve paths, pretty much anything in the whole abdominal area, in through the spine and pelvis. So it's kind of it's not just that little sling of muscle, it's everything else around the entire area. So when people say kind of like, what area do you treat? I'm pretty much treating like here to here, because that pelvic floor can really impact everything along the way. All ages, I do see the youngest I've seen is probably 3 or 4 years old, and then people into their 80s and 90s. So there's no age limit on rehab, right? We can always improve. Not everybody does see men and children though. Some pelvic floor therapists do choose to keep their practice female patient oriented. So there's a couple of us at Spectrum. I think there's just 2 of us that see men and children. And then we see anything from acute symptoms, something happened, within the last couple of weeks, to people that have been dealing with symptoms for decades. Okay. So it's never a time limit on this. Just because somebody might have had symptoms for years and years and years doesn't mean that we can't help them. There's no time limit on, oh, you've had pain for 10 years, sorry, 40 years, sorry. We can always help people. So diagnoses that I see, anything having to do with bowel bladder, so incontinence, retention, constipation, the vaginismus and dyspareunia are painful intercourse diagnoses. Interstitial cystitis is a bladder condition. And again, any pain in the area of the pelvis, low back, scar pain, including abdominal stuff. So it doesn't just have to be scar tissue within like the pelvis or pelvic floor. I see a lot of people post-surgical stuff within the abdomen, whether it's hernia repairs, diastasis repairs, even little things like appendectomies and things like that. And because we have such amazing technology, and when you look at somebody's abdomen after having like a scope for something, those scope incisions are very deceiving, right? They're little, they're tiny. It looks like minimal things happened in there. That does not show what really happened on the inside. So you could look all well healed and you've got these little tiny incisions, but on the inside, it might be a completely different picture as far as scar tissue and immobility of some fascia, and things just may not be moving well. So I see a lot of scar pain, and we mobilize all that tissue to get things moving. In fact, usually if we have anybody come into the clinic with any type of scar or anything, my coworkers always come grab me and they're like, can I go grab Jen? She's going to want to see the scar. And I come in there like, I love scar tissue. I love working on it. So, all right, history. How did we get here? Like, how do I even have a job, right? Like, why is this even a thing? So back in the 40s, believe it or not, it's been around for a while, but it really hasn't picked up steam. And I would say until the last like 30 years or so, 20, 30 years even. But there was a physician and he did some early work with incontinence patients and thought, hey, there's muscles there and we do have some control over them. So what happens if we exercise them? And he developed this perinometer, which was like these balloons that he would insert and these tubes and air pressure so that when you squeeze the balloon, the volume of water would rise. And that's how he used to kind of first initially start to measure some of the strength and pressure that we could develop within the pelvic floor. And then it was like these patients got better. And it was like, oh, ding, ding, ding. Oh my gosh, we can exercise these muscles and affect symptoms. But we're talking fast forward decades, right? It wasn't until the 90s that my national organization for physical therapy said, hey, those are muscles and ligaments and connective tissue and joints, just like we work on the rest of the body. So why is that not within our scope of practice? So they did determine, yes, this was no different than working on any other muscle group, joint, space in the body. And that was definitely part of our scope of practice. And then we could do pelvic floor. All right, so when you first come in and see me, I give you credit, one, for walking in my door. Sometimes it takes a lot of bravery for people to come. It's not always the most comfortable thing to be talking about bowel, bladder, and sexual health with a total stranger. And a lot of times people are telling me things they may not have ever told anybody before. You know, I hear that probably almost on a daily basis, for sure a couple times a week with, oh my gosh, I can't believe I'm telling you this. I've never told anybody this before. I haven't even told my doctor. But that honesty is what we need. If we're not getting the whole big picture of what's going on, then I can help you, we'll help you, but there might be some missing pieces to that puzzle. So sometimes things come out even second visit, third visit, fourth visit with somebody where they're finally comfortable and saying, I didn't know how to tell you this, but like this happened to me. And this is, now I'm remembering when, I'm thinking about back to my history, there was that time, I fell and, so all sorts of things kind of start to come out sometimes. So we do a lot of talking. I want your history, what's going on, how long have you had it? And lots of education. I feel like sometimes, there's a little information overload first day, because I want you to understand everything. You've got to understand why we are in that space in your body and what we're doing there, right? And it goes for anything, right? If I were to touch your shoulder or your knee, like I want you to know why. This is why I'm touching your knee. This is what we're doing. This is what you should feel and wear. Pelvic floor, probably maybe a little bit even more important, right? It should never be a surprise when I move my hand in that area of the body for somebody. So they really need to understand the anatomy themselves of why we're looking in the space and where are we going and what we're going to be doing. So I want you almost like a little mini pelvic floor therapist when you come out with all the education you've got. The exam, We'll do like a back and hip screening for exam, but pelvic floor assessment, as far as internal goes, female, we have two options. We have vaginal and rectal exam. So somebody may have one or the other or both, depending on what I'm seeing them for. Men is the rectal exam is the only option for internal exam. So we do external as well. I have some women or patients that are just so painful, maybe we can't get to an internal exam just yet. So there are a lot of external exam techniques and treatment options to treat that first layer of muscle that sits right below the skin before we would even do anything internal. And sometimes people didn't know. They come in and I'm like, did they tell you? Central scheduling scheduled you? They're supposed to inform people like, hey, there might be an exam. They didn't get told. Some people just like to know that ahead of time. So sometimes we'll push an exam off to the second or third visit because I want people to be comfortable with it. And I want to meet them with where they're at comfort wise and never do anything that they really don't feel comfortable doing. Home programs are key. I can help you, but there's a lot of this that you have to be doing on your own. Okay. It's not, I'm good, but I'm not magical. I can't just like touch your abdomen and make all your pain will go away. Like you have to be doing this stuff at home. So there are things that you have to do, just like for your shoulder or knee. You know, they might give you 3 or 4 exercises to do at home to help with your shoulder. And then you're doing different things in the clinic when you go in for physical therapy. So it would be different things than you would do with me in the treatment sessions. And then we would talk about, yeah, what do we need to do? So after we do the exam, we talk about what we find. This is what we're going to do for treatment. Does that sound okay with you? We've got a plan. So people are never surprised next visit. I want people to know when they're leaving, what to expect when they come back. Because again, nobody likes to be blindsided by different techniques and stuff that we may do. And I really need to know what your goals are. Everybody is so different. You know, do you want to jump on the trampoline with your kids and not pee your pants? Like that's a biggie for people. You know, do you want to be able to go to your exercise class and be continent? Do you want to be able to make it through your water aerobics class and not have to leave in the middle of it to go to the bathroom because water is a big bladder trigger? You know, and so it's exercise. I want to be able to walk. I want to just be able to do regular everyday life around my house and not feel like I'm falling apart by mid-afternoon and everything's falling out of me. So it's trying to figure out what are your goals? What do we need to work towards for you? And that's so different. You know, somebody might just want to get up out of a chair without leaking versus the next person that comes in and they want to run a marathon without crossing the line and their shoes are soaking wet, not from sweat. So, which I've seen that very often. So how often you would come is not like a traditional physical therapy visit. If anybody has had PT in here, you were probably in there a couple times a week for X amount of weeks working on things. I see people once a week, usually at the most. Okay, because there is a lot of stuff that you need to be doing at home, and bowel bladder systems do not change overnight. If I see you today, 2 days from now, if you were to come back, there isn't a ton that's going to be different. If it's a strength issue, strength takes time. If it's a flexibility, mobility issue, that takes time. So I'm there to kind of help guide you, and you need me for things that you can't do at home. But again, a lot of this is like balls in your court. You have to do the work at home. And then I'm seeing you once a week, maybe for pain, usually once a week for like 4 to 6, maybe 8 weeks. And then we start spacing out from there. If it's just a strengthening issue, then I might see you once or twice a month to progress your exercises. And then when you come back, what's going well, what's not, change this. Okay, let's progress this, go away again for a few weeks. So typically for strengthening, I just see people like 3 to 5 visits, just like spread out over several months. And then pain patients, again, that's a little bit more variable depending on what it is that we're seeing them for pain. I see them a little bit more frequently. All right, so under active, what can we do? We can strengthen, right? If you had a weak arm, you'd work on it, you'd strengthen. If you have a weak pelvic floor, got to strengthen it. So it's working on the whole core system, it's body mechanics. Posture is actually super closely related and linked to incontinence. If I have a thoracic kyphosis and my pelvis is tucked underneath me, it takes your pelvis and it tips it flat like a bowl. And now everything can just drop out the bottom. So flat back tucked tailbone is actually really highly correlated with risk of incontinence is posture. So even just working on posture for somebody and getting them into a better position so those organs are better supported within the pelvis is super important. And then different strategies. How do you learn to use what you have? Just because you have a strong pelvic floor doesn't mean that you're using it well. If you can't contract it while you lift a heavy laundry basket or, you know, To pick up my 82-pound dog the other day to get her in the tub. You know, if I can't contract and lift her at the same time, it does not support me. It doesn't matter versus somebody that might actually be a little weaker, but they are so functional. They can use their muscles. They are coordinated. They're probably going to do better than that person that's super strong that just can't manage to multitask and use their pelvic floor functionally. So we got to be able to learn to use it on manual and get it off of autopilot. Lots of retraining, behavior changes. So that bladder bowel retraining is, it's behavioral. We got to change behavioral stuff for people. It's huge. You could be super strong and still be having really bad habits and you're not going to really get anywhere. Okay. Pessary, I don't fit them. That's something that is a prolapse supportive device that you would be fit for in a physician's office. So they can hold up different structures. So if somebody's prolapsing bladder or prolapsing the rectal wall or their uterus, anything like that, men can't get fit for pessaries, but women do. And then it's a non-surgical option that helps kind of support everything up. Or maybe somebody is a non-surgical candidate. They can't have surgery for whatever reason, or maybe they're trying to put it off for a couple years. That is something that can be fit. So to me, it's like a knee brace. It's just the different shapes and sizes to brace those organs and tissues. Overactive, if things are too tight, not moving, and we got to get it moving, right? We have to learn to relax. We have to stretch. We have to learn to breathe. Manual therapy. So if there's anything that you can't get to at home, then you need me to move those tissues. Biofeedback is really kind of cool. Biofeedback is actually a computer system. So we have these little sensors that go on the outside of your pelvic floor, and they kind of look like EKG sensors. And that's really all an EKG is. Like when they, when you see the little heart blip on the screen, it's a form of biofeedback. It's anything that you can now see contraction wise that's happening in the body. So we've got little sensors that we can put around the pelvic floor, and then we can watch it on the computer as you contract and relax those muscle groups. You can see it, which is super helpful because this is inside your body. You can't see it. I would have no idea if all of you right now are contracting or not. I have no clue. And usually by the end of class, people are sitting here like trying to contract and like do things. But it gives us that visual picture. So do we need to work on up training and contracting, or do we need to teach somebody to relax? And so with that on, we can figure out, is there a good position for you to be in to relax? Maybe somebody should be on their right side with 2 pillows between their knees, and then their pelvic floor just drops and relaxes. So it gives us a really good visual information about what we need to do at home. And then again, retraining, the eStim TENS unit, if anybody's ever used it for pain, it's like a little battery powered home unit. They're actually just a little bigger than this. People can use them for back pain, but I use them a lot for abdominal pain, pelvis pain, that kind of thing. And they're like $30 on Amazon. So it's a really effective, inexpensive way for people to have some pain control options at home that are not pharmaceutical. Heat, ice, if it hurts, try some heat and ice. All right. We're stuck. I'm not sure why it's not moving. There we go. Okay. All right. So let's talk about different types of incontinence. There are several different types. Okay. It's not just one size fits all. So stress incontinence is when your abdominal pressure basically exceeds the amount of pressure that your bladder neck and your pelvic floor can push back against. So if this is my bladder and this is my urethra, and I've got my abdominal muscles up here and all my organs, and I cough or sneeze, and you get this poof of pressure, then if this can't fight back against that, you get leak, sneeze, jumping, boop. Okay. So you get that opening of that space, and that pressure exceeds what it can force back against that. And that's what leads to that leakage with that. And it doesn't have to be excessive. It doesn't have to be jumping, running. It can be literally just getting out of a chair. I see a ton of people that leak happens as they're sitting to stand, that transition, because maybe they have a tough time getting out of low chairs. Maybe they hold their breath and they're straining. I don't know if I catch myself once in a while making noise when I get out of a chair now, which I'm like, oh my gosh, you get up and you're like, and you're like pushing, and like, if it's a low surface. So any type of breath holding with movement and transition, that is going to force that pressure and stress to cause some leakage. Urge is that like, I have to go and I have to go now, get out of my way. There better be nothing in my way. Maybe you're getting in the door. You can't even get your shoes off or your jacket. And you are just like shoving your kids out of the way and like running for the half bath, right? That's urge incontinence. And sometimes it makes sense and sometimes it doesn't. Maybe again, healthcare and teachers, they're notorious for holding it way too long, right? Because we go from patient to patient to patient. Elementary teachers, especially, they can't leave the room unsupervised. So they make up a large base of that. They wait too long and then they're running down the hallway, right? And they can't control it. It's also urge incontinence when it doesn't make sense. Maybe your bladder is misfiring and there really isn't that much in there. And you really thought you had to go and you went in and sat down and tinkle, tinkle came out and you were like, that's weird. I felt like I had to go. My bladder told me I had to go, but like nothing much came out. So that's an urgency. That's when that urge doesn't really even make sense. So your bladder can misfire as well. And then you can be really lucky and have both. You could have the combination, right? I'm sneezing, coughing, leaking, but I'm also not making it to the bathroom in time after urge. Okay, so you can have that. And an overflow are usually some of the folks that are holding it too long. You do hit a tipping point. Even though that bladder is a balloon of muscle and it just stretches, at some point, it's going to not be happy with you that you keep making it hold it. And it's like, I'm done. And then you just get leak. Okay. All right. I'm a nerd about statistics. I love math and stuff. So I always got to throw some statistics in because it blows my mind when you see the numbers of really who's dealing with this in a general population. More than 50% of nursing home residents. And a lot of times that's what even provokes people starting to look at assisted living is loss of bowel and bladder control and inability then to care for their perineum or change effectively and care for themselves. 1 in 3 female soldiers. That's a lot, right? We're not thinking about that, but when they've got their gear on and their belts, and I've treated several soldiers over the years, like that's like 50 plus pounds. Like I forget, it's a lot that they're hiking around with. And when they got to go to the bathroom, it's not that easy for them. So then they end up holding it because they've got to take everything off. Men don't. So we actually, I fit all my female soldiers. I get them, there's actually a standing female incontinence bladder relieving device. One of them is called a Shiwi, and it's like a little funnel in a little cup that you can use standing up that has like a little spout, like a funnel, and they can pee standing up and they don't have to take off their gear. Hiking is the other group. Women who are out doing long hikes and in places that it's just not as easy for them as men to maybe be able to avoid in the woods. It's like, that's not so easy. And they hold it too long and then they don't make it back and they leak. So there are lots of tricks and things and devices and stuff that we can use to kind of help this population. 1 in 3 community dwelling females is incontinent of some kind. Again, that's pretty big. And that's just if they're admitting to it. The thinking is that there's a lot of people that just don't, they think, oh yeah, I pee once in a while. I don't really consider that incontinent. And they'll just mark, no, I'm not. But it's like, yeah, if you have anything coming out when you don't want it to, that is considered incontinent. I don't care if it's, 1% of the time or 99% of the time, it's still a yes. And people don't talk to their doctors about it. Doctors don't ask. And they've done some research on why they don't ask. And the number one answer usually is they don't have time. They've got a finite minutes with you in that room to cover whatever it is that they're there to cover. And if you come in and they want to ask you about bowel health, bladder health, back, pelvis issues, sexual health, if you say yes, you have an issue, they don't have the time to then deal with it. So a lot of times they're not asking, and then people aren't admitting because they think there's nothing that can be done for it anyway. So then round and round we go because nobody's getting any help. So talk to your doctors, okay? Only 3% of people will spontaneously talk to their doctor about it. It's not very high. And then even when they do get asked, a lot of people won't admit to it because again, they think it's not a big deal or nothing can be done about it. And so they're like, yeah, no, not really. It's not really a problem, but maybe it is. And if they found out there was help for it, then they would completely take advantage of getting that help. So again, just kind of the main one on here that I want to highlight is verbally instructing people on how to do a correct pelvic floor contraction. Research shows that only about half the people are going to do it right. 50% are going to do it wrong. And of those 50%, 25% of those people are going to do it so wrong that you're going to make yourself worse. That's huge, right? So that's part of why it is that we have to do an internal exam. If you're sitting across from me in my room and I'm instructing you verbally on how to do it, I don't know which part of that group you are. Are you the group that's actually doing it or not doing it so bad that you're going to make yourself worse? So it's like teaching you, it's like me showing you how to do an exercise and then just giving you the TheraBand and a picture and going home. Odds are you're going to get home and you're going to be doing something like crazy with your arm because we didn't look at it in the clinic to make sure that you were doing your exercise correctly. So we have to make sure you're doing it right. That's number one. And then sometimes we still have to check a couple times in a row because people are like, they'll come back and they'll go, I still don't think I'm doing it right. So sometimes we have to just keep checking until we can make sure that they are. Now, the no pregnancy thing, don't think just because somebody doesn't have children that it's going to save them down the road. It doesn't. There is still a very large percentage of female population without pregnancies or vaginal deliveries that are going to end up with some sort of incontinence or prolapse. Okay, so sometimes women are like, oh, I had a C-section, I'm good. No, you're not, because pretty much when you look down the road in the future, they have almost identical issues with like incontinence. So there you go. And this is the big one, right? This is right here, like highlight, bold it. Incontinence is not considered a normal part of aging. That's huge. Like I remember hearing that thinking, wait, what? Like that just blew my, and I was like, well, if it's not considered a normal part of aging, then why aren't we more proactively going after this? Why aren't physicians asking? Why aren't people getting the help that they need? I feel like what other thing that we consider go wrong and we're just like, it's fine. Like, no. So get the help. It's out there. All right. Normal bladder function. You should be peeing about every 2 to 4 hours on average. It takes about that long for your bladder to fill. So as your kidneys are making that urine and dripping into your bladder. So 16 to 20 ounces is a really full bladder. So a couple cups of urine. Under the age of 65 at night, we do not consider it normal to be getting up regularly. Over the age of 65, once, maybe twice. Sometimes we're dealing more with medication issues at that point, leg swelling. So people are notorious for having some foot ankle swelling. You go to bed a couple hours later after your body pulled all that fluid out of your ankles and legs, you're getting up and you're peeing out your ankle fluid is basically what you're doing. So if you have some swelling issues, make sure like an hour before bed, you get them elevated. And elevated is not sitting in a chair and then just putting your foot on the coffee table. That is not above your heart. That is not elevation. So you have to really get it above your heart, do some ankle pumps, let some of that fluid come out so that when you go to the bathroom before you get in bed, maybe now you won't be getting up in the middle of the night to get out all that ankle fluid. And again, medication, diuretics, blood pressure, stuff like that. That's why over the age of 65, sometimes just some of that plays a little bit bigger role, but we still try to minimize it because every time you get up, you break your REM cycle and you lose an hour of quality sleep. And most of us are not sleeping enough as it is. And then you take away some of that quality sleep because you're getting up 3-4 times a night. No wonder we're all so tired, right? Yeah. All right. We should be able to hold it 30 minutes after urge. So I shouldn't have to drop everything and run. If I'm doing dishes, I should be able to finish them. If I'm, folding laundry, I should be able to finish it. I should be able to make it a couple exits down the road till we get to the next rest area. Like, not a big deal. We should be able to hold it past that. Now, pelvic floor exercise, that Kegel, normal is bare minimum. I should be able to stand, hold it for 10 seconds, do 10 of those, and then do 10 2-second holds. 70% of your pelvic floor muscle fibers are built for endurance. 30% is built with quick power and speed. So all of our muscles in our body have different types of muscle fibers depending on what that muscle's main job is. Your pelvic floor is built for endurance. It's got to do all those jobs all day long. Okay, it's got to hang in there like a marathon runner. But every once in a while, it's got to do a quick sprint. So we do have to work it both ways. And usually the endurance piece of the puzzle is the missing piece. It's the biggest piece. It's what's missing. People cannot hold it more than a couple seconds. And if they can, it fatigues fast. So that's usually what we end up having to work on. For my little kiddos, pediatric patients, I do not do internal exams. We just don't. But for them, how do we know if they're finding their pelvic floor? I'll send them in the bathroom and they get to pee for me. And then I tell them, see if you can stop it. and they come back out and they tell me what happened. Yes, I could stop it and restart it. Great. I know they found their pelvic floor, and it gives me some idea of how much strength they could generate to pinch that urethra. If they could go to a trickle, or if maybe the stream deflected somehow or nothing happened, then it gives me some information on, can they find their muscles? So sometimes people still come in, they're like, oh yeah, my doctor told me to do that like every time I go to the bathroom. Please don't do that. It's gonna, it trains your body to basically be dysfunctional. If you're supposed to sit and relax and allow urine to come out and you keep trying to slam the door shut, your body's gonna learn to do that. So then I hear people, it's like, oh, well, now I don't even have to try to do that. Like my stream is just like start, stop, start, stop. Like I have to really focus on relaxing. So if you do try this once, maybe twice a month, and that's it. This is not something that you need to be doing all the time. It's a test. That's it. Okay. So just a little disclaimer on that. Do not do that all the time. Bad habits. We think if we don't drink anything, it won't be a problem, right? Maybe I won't have to go to the bathroom as often if I don't drink anything, or maybe I won't leak. That actually can make things worse. Your urine gets very concentrated, and that is very irritating to the lining of your bladder. So your bladder is going to want to get rid of that. It's like hot sauce. But if you dilute it and it's pale yellow clear throughout the day, that's the goal, pale yellow clear. So sometimes people are like, well, how much water should I be drinking? Is your urine pale yellow to clear? Yes, you're good, right? Maybe in the summer, a little bit more. If we're sweating a ton, you're going to have to drink a little bit more to replenish those fluids, right? And if you're not letting your bladder ever fill to capacity, it's going to keep losing flexibility over time. So people swear they have small bladders. They'll come in and sit down and go, oh yeah, I've always just had a small bladder. That my family's always teased me. And I'm like, oh my gosh, yeah, John's got a small bladder. It's not that they have a small bladder. What they've done is they've trained their bladder to hold less and less and less over time. So their bladder's lost some flexibility. If we don't stretch muscles, we lose flexibility, right? If you could do the splits a couple of years ago and you haven't stretched since then, odds are you're probably not getting in the splits today because you didn't lengthen that muscle. Yeah. So bladder muscle, we have to keep lengthening to keep that flexibility there. Okay. Bladder irritants. These are different for everybody, but coffee, pop, alcohol, tea, even decaf, carbonation. I'm finding this is a huge one the last few years now that all these like sparkling waters are all popular. Is I'm having to take away that carbonated water from a lot of my patients because they're figuring out that's their trigger. Because they'll say, oh yeah, I'm drinking water. I'm like, why are you still so urgent? We're trying to troubleshoot and we're like figuring out their diet, and they're keeping a bladder diary for me and they're writing down everything. And I'm like, what are you doing? And they write down like they're drinking the sparkling water, and I'm like, carbonation. So carbonation can do it, artificial sweeteners, spicy food, high acid content food. And again, it's different for everybody, but if you can figure out what your triggers are, then you have control. Because if you know, wow, every time I eat fresh cut up pineapple and it's kind of acid, my bladder's not real happy for a couple hours, that is not probably the go-to snack before you meet friends for a 3-hour movie, or to go walk, or to get on a plane and travel, right? So it does give you a little bit better control if you're figuring out how your body responds to what you're putting into it. Just in casing, we should not be going to the bathroom just because you are leaving the house, right? Which I won't ask you to raise your hands about how many you did like before you came here. Yeah. Right. And then you probably went when you got here, and the people are going to go before they leave, and they're going to go when they get home, and they're going to go because there's one in the beginning of Target when you just walk in the door, and their friends going, I might as well go with them. So women are notorious for this a lot, but men get in the habit too. You don't pass up a bathroom. If you're not letting your bladder again fill to capacity and you're going more often throughout the day, you're losing the flexibility of that bladder to expand. You're training your bladder to signal you to go more often because that's what you're doing. So is it any wonder that our bladder over time continues to signal us that it has to go all the time when that's how we've trained it? Okay. So it's getting in the habit of like, you grab your car keys. When did you go last? What have you had to eat and drink since then? Where are you going? What are you doing? Should you really be using that restroom or not? If it's borderline, it's been an hour and a half, so it hasn't been 2 hours, but you had coffee, which is a trigger, and it's blizzarding sideways and you're driving to an appointment across town. Yeah, that's, I'd okay, go. If you don't, that's fine too, but that's kind of borderline. You had an irritant, the weather, who knows how long it's going to take. Maybe you get stuck on the highway. So I never want people to put themselves in a position where they're uncomfortable making those decisions. Like Jen said, I shouldn't go, and I grabbed my car keys and then I got wherever and I was really panicky because I wasn't about, it's like, no, I don't want people to ever feel that way, but it's starting to eliminate those few little times a day. Do not wash your face, go to the bathroom, brush your teeth, get in your jammies, read for 10 minutes and get up and pee again. You just went. Like, it's impossible, your bladder's full. So you either just flip that light off after you read and go to sleep, or you don't do the one while you're washing your face. And after you read, if that's the one you like to do, then you keep that one. So it's about eliminating some of those extra times in the day when you really don't need to be going, okay? Squatting, please sit. Squatting keeps the pelvic floor and hip muscles and back muscles engaged. So I always tell people this, make sure there's toilet paper in there too. Take some toilet paper, make your little nest, sit down. Okay, your pelvic floor is going to relax so much better. Your bladder is going to get a better empty so that you don't have as much left over. And there is always leftover. Your bladder's never totally empty. It actually holds back a residual volume of a couple ounces. So don't think you're not emptying. If you're done peeing, because people say, oh, but if I push, I can get a little more out. So I don't think I'm emptying. It's like, no, you're pushing out what your bladder wanted to keep back. And you should never push and strain to empty your bladder. Okay. You're just going to keep pushing your bladder southward. Okay. So we shouldn't be doing that. All right. Bowels. Switching gears a little bit. Let's talk about some bowel health. What's normal? This is a huge range. As little as like every other day is normal, up to 3 times a day. That's huge, right? Like, there is not this like one size fits all. So if you're only going once or twice a week, that is not enough. If you're in the bathroom, 5, 6 times a day, that's too much. And it's really about what happens during and how do you feel in between. This person over here could poop every other day. When they go, it's soft and formed. They're not straining. They feel great. They don't feel like on the day they don't go that they wish they could, and they're bloated and ugh. And then this person over here that poops 3 times a day might be straining and pushing and breaking a sweat and feeling like they're giving birth and it's pellets coming out. They're pooping 3 times a day. But if that's all you knew about them, you'd think, oh no, they're not constipated, until you find out all the other stuff. And then you're like, oh yeah, they are. And then this person over here, they're fine. It's easy peasy, soft formed, they're good. So it's not always about frequency. It's about what happens when you poop and how do you feel in between those bowel movements that would indicate really more about that constipation or not. So we don't like straining. High fiber diet, plenty of water, right? Usually this is not news for people. We need to be eating healthier and drinking water and moving. Part of moving throughout the day, exercising, is that little massage and movement to our intestines. It helps move things along in there. The more sedentary we are, the more sedentary our gut system is. Okay, so movement is key as well. Let's see again, some statistics, right? Fun facts. This one blows my mind. Okay, so when we talk about gut health, and you guys have probably heard a lot about like probiotics and prebiotics, and that there's natural bacteria that live on our body and in our gut system. 95% of your body's serotonin, which is like a happy mood chemical for our brain, is made in your gut. So happy gut helps with happiness, right? Like, we feel better because we've got that serotonin being produced there. And that's just one thing, right? There's like a bazillion things that our gut is in charge of helping with. That is huge for the rest of our body's health. 7 liters of fluid are moving around our gut on a daily basis. That's a lot of water, right? In and out of that system. And then there are hundreds of different kinds of bacteria that live in our gut, like hundreds of different kinds. I will look forward to the day when they could just do a little sample and like figure out like what I'm actually missing and then give that supplement, right? We're not there yet, but at some point in the future, like Star Trek kind of science, right? Like, I want that to be a thing. I want that to be like, they can easily figure out what bacteria you're low in your gut, what you're too high in, and figure those levels out. But we're not quite there yet. We have some studying left to do. But the other interesting, cool thing is when we're little babies and in the womb, our intestines are sterile. We haven't been colonized yet by that bacteria. What colonizes us is the birth process. So vaginal deliveries, as you're passing through that vaginal canal, which has its own microbiome and bacteria that live there, it gets all over baby. And that starts the colonization process and how those bacteria get into the gut, as well as breast milk. Okay, so what happens with C-section babies? There actually is a difference. So if a baby's born vaginally versus C-section, they're finding a huge difference in their microbiome after birth, and then for quite a while into like, infancy and stuff. And so over those first few years of our life, the kinds of foods we're eating, the kind of bacteria that we're exposed to, all of that helps colonize that gut. So I know there's a lot of old research and stuff that was like, let your kids eat dirt, right? Like just let them play in the dirt, let them get dirty. Like let them get dirty, like let them get exposed to all that bacteria stuff. We're very sterilized now and everything's antibacterial and cleansed, and we're not really being exposed to a lot of the things that we used to once upon a time. And so we're missing a lot of bacteria that used to really help with digestive health. And our food is very different now than it used to be. So it's like our bodies haven't caught up to all the changes in our food and our environment yet. So we got to figure that all out. All right, fecal transplants. Did you know that was a thing? It's a thing. Yeah, I know. This blows people's mind. They think, think like heart transplant and kidney transplant and all this stuff that we can transplant. There's a fecal transplant. The research is super interesting on it too. Right now, it's only okay to be using for the C. diff population, which is like an infection, really hard to get rid of. They're doing really great with that. But what they're finding though, is they're looking at all these other things. Again, obesity, that population, their bacteria in their gut is different than when you're looking at healthy weight individuals. Mental health, again, if you go back to the serotonin piece of things, they're looking at a lot of correlation between gut health, the microbiome in there, and mental health. So if we're missing all of this stuff in there and it's affecting us physically and mentally, what if we could transplant the stuff in there? What if we took the fecal matter from a healthy individual and put it in somebody that wasn't so healthy? And they're finding really good things are happening. So that's essentially what it is. You either go under and they put it in via colonoscopy, or there is like a nasal tube that they can do right into the stomach area. But that's one of those things that's probably going to be real up and coming. Constipation, again, what should it look like, right? We actually have a poop chart, right? And I've got to know what's coming out. And sometimes people look at it and they go, well, gosh, I have that all. Like, it just depends on the day. Like, okay, but we want you to settle in a specific area. So usually 4 or 5 is kind of, we want it soft. So it should be soft and formed, like overripe banana. Okay. Sometimes even a little fluffier if people have a history of chronic constipation or pain or fissures or active hemorrhoids, things like that. We kind of want it super soft. I don't want it liquid, but soft, fluffy might be okay for that particular person. But if it's starting to be real too formed, cracks, pellets, things like that, that is considered more on the other end of the scale that we don't want you on. Okay. And then things that affect our digestive system. As we get older, that peristalsis does slow down. So peristalsis is that wave of activity that helps push things through your gut. So I'm a visual person, like I see pictures of things when I think about stuff. And in my head, it looks like a caterpillar. Like, a caterpillar just kind of like moves its way on down, right? In this like little rhythmic wave. That's kind of what's happening in that intestine throughout the day, is it's got to move. And when we eat something in the morning or for meals, it kicks off a gastrointestinal reflex. It kicks that peristalsis off. So that's why most people are morning poopers. But when you eat something and you kick off that movement and it helps move things along closer to the exits, then usually 30 to 60 minutes after we eat is when most people are going to poop. But as we get older, that wave does slow down a little bit. That's why all this other stuff is so important. What's happening with medication, that'll slow things down. Pain medication, calcium channel blockers, iron supplements. If somebody's anemic, there's all sorts of medication that is either going to slow down the transit through your gut, dry things out. Antihistamines, right? All that stuff just like dries everybody on out. You got to be drinking water then to be kind of counterbalancing all that. Inactivity is, yeah, I'm not moving. Maybe I had a surgery, maybe I had a joint replacement and I just haven't been moving as much as I used to anymore. movement helps things move here. So if we're not moving, odds are our gut's not moving real well either. Again, water, happy bowel and bladder, we need fluid, we need water. Diverticular disease as we get older, it's not really a matter of like if you're ever going to get diverticular issues, it's probably usually when. It's just little pouches in the lining of the wall as that kind of thins. It's just we don't want it to be inflamed, right? We don't want the itis part of it. Diverticulitis is the inflammation piece of it. So, fiber helps kind of keep everything moving through, and we'll talk about that in a second. So diet is huge for bowels. Stress, right? If you're really stressed out about something, people can swing either way. It can give people the runs or it can back them up. And maybe it's good stress, right? Maybe they're going to be going on a trip and they're just like, oh my gosh, I got to find a babysitter for the dog. And, I got to pack and, I got to, and they're just like super excited, but there's a lot of stress and I got to remember to, Outlook emails, and they're just like all over the place. That can have a really big impact on the bowel and bladder. It's just what's happening in our everyday life for stress. And then other things, thyroid issues, strokes, all sorts of other conditions can affect bowel and bladder. Now, what might we do to help you, right? How are we getting these things moved along? I'm going to teach you guys how to do a little colon massage, little intestine massage. It feels wonderful. And it's something that you can do to yourself. I used to do it on my little babies when they were little and all gassy and help them move gas. It shouldn't be painful though. And it does just manipulate the bowels enough that it stimulates that peristalsis wave. Pelvic floor retraining. Why are you constipated? Is it an above the pelvis issue, a below the pelvis issue, or is it both? Do I have a slow transit, or is it the exit? Is my exit not relaxing and opening? Are those muscles too tight? Are they too weak? Weakness doesn't mean things are coming out easy either. Weakness usually means there's probably some prolapse. That rectum is not well supported, so you have to strain harder because it's not this nice supported tube. So do we need to strengthen? Do we need to relax? Do we need to stretch? What do we need to do? Bowel retraining behavior. Behavior, again, is a biggie. It's that every day without fail, you need to be getting up, drinking a glass of water, eating a little something, giving yourself 30 to 60 minutes, and then taking the time to toilet. Men in here, you guys are probably great because men traditionally will take time. They'll sit. You guys will just take time. If you probably polled most of the women in this room, we have like 100 million better things to be doing than sitting on the toilet. And women do not take the time. If it's not happening in 2 minutes, they are off that toilet. All right. They just don't sit. I had a lady come in yesterday and I wanted her to sit for 5 minutes. And she was like, oh, I just can't do it. It's too long. I can't do it. It's forever. I'm like, can we start with 3 minutes? Like, can I meet me halfway? Like, you got to sit for 5 to 10 minutes. That's kind of the average time of how long you should be sitting, because it's not like it's all just sitting right at the exit and like a door opens, boom, and it comes out and like you're done, right? It's a long tube. So you got to give that peristalsis a chance to move things from part of the sigmoid colon back around towards the exit. Okay. It's not just going to like magic 10 seconds. Now, sometimes men sit too long and they're in there too long, but usually 5 to 10 minutes. If you have not had anything else come out, or people are constipated and they're straining, and people will come in and say, I sat on the toilet for like an hour. No, if nothing came out after 10 minutes, like you need to get off that toilet and move about your day. Okay. So you can sit too long, but a lot of people are not sitting long enough. So it's behavior. It's how are we training your body to have that expectation of time of day to poop, ease of poop. Rectal balloon training. I don't always use this with people, but sometimes people come in with doctors that have specifically requested it. There actually is a little catheter and a balloon that will insert rectally to retrain that area of your body to be able to sense what's truly happening. That communication between that rectum and your brain can be completely shot off track. If I have had chronic constipation and that rectum has been overstretched, it's a megacolon. It can hold it for 7 days. I mean, I've seen people that haven't pooped in 2 weeks. That's a huge colon, right? Like they can just keep holding and holding and holding. They never feel the urge to poop. because they can just keep holding it. And then somebody can actually have like a microcolon where any tiny little fleck of anything there gives them really strong urgency. So we have got to retrain those tissues in what is normal. So then we can work on inflating the balloon, deflating it, and then they have to tell me, am I filling it? Am I taking air out? So that they start to understand what does it feel like when something's actually there, and what does it feel like when it's empty? So it's a very interesting technique, and it's really super effective. Fiber, water, I already touched on this a couple times. Manual techniques, again, if something is not moving well or is restricted, then we need to do some mobilization to that area to allow that exit to open easily. And then positioning. Right? America's toilets have gotten so tall because we can't get off of the lower ones. So, right? Yeah, right. And again, I don't ask for raising of hands, but like half of you probably have like a raised toilet or something that's a little bit higher because it's just so easy to get off of, which is great, except that it changed the mechanics of our body. We are meant to squat and poop. If your knees are not above your hips a little bit, your pelvis is in a completely different position than the mechanics of how to position that rectum for a good empty. Okay. So we have to bring the floor up to you typically with stools and things like that. My grandma's house was like built in the 50s and she still had all the original toilets and they were low. Love her toilets. They're amazing. So I know, right? It's like I go to her house in Detroit. I'm like, Grandma, your toilets, they're so great. So positioning does matter. And then again, what's the muscle response? Are you relaxing well to allow things to go out? And there actually is something that happens where people push and their muscles contract and close the door further, which is a dyssynergia, which actually does happen quite a bit. Massage. Okay, you ready? Okay, we're gonna teach you how to do this. So if you walk away with anything today, you'll know how to do a little belly massage. So your small intestine, basically, if you put your hand on your belly button, you're pretty much over the entire small intestine area. Okay, and then your large intestine is shaped kind of like a rainbow or a boxy rainbow outside of that. So with intestine massage, what we have people do is around your belly button, and I don't care where people start, you would apply a little bit of pressure in and you do these lovely, just little overlapping circles, clockwise pattern in a clockwise direction. If you hit something that's painful, it is not a no pain, no gain. Don't start digging around in there thinking you're going to help move something along. Your brain's going to feel that pain and it's going to clamp it down to protect itself. Go a little lighter, or maybe just skip that one little spot. But once somebody goes around that small intestine a few times, then they start on the large. And if you find your pelvis bone sticking out there in the front and come just to the inside of that and down a little bit, that's where your large intestine is starting. That's why, like, so your appendix lives there at the start of your large intestine, which is why if you have pain down here, that's why we get concerned about appendix. Same thing, overlapping clockwise circles coming up around that large intestine, following it up around the rib cage, across the belly, down the left side. You're using your bone as your landmark again and down into your left low belly. And then from there, it goes back, forward, out. Like it does this little roller coastery turn thing right at the end, which is why you have to give it time when you're pooping to kind of make those little torturous turns there. So you can do overlapping circles. Sometimes people like to do a like a smooth, more of like a bigger circle type of thing. They may spend a little more time on one side of their abdomen versus the other. They may find that, gosh, if I push over here, I really get things moving. Great. That is something so absent-minded that you can do while you're watching TV at night, or if you get in bed at night and you are not a fall asleep instantly kind of person, lay there and massage. It feels good. It's very relaxing. It helps stimulate things. If you're gassy, bloated, feel like things always get stuck in one little section and you're like, I just can't move it. You massage it out. Get that wave of peristalsis happening there. Okay. I'd like to say that was a picture of me, but it's not. Just got that whole six-pack thing going on. Okay, now bowels do like a regular schedule. When I mentioned getting up, eating, drinking, that kind of thing. We like regularity. Our bowels do not like, well, sometimes I make time to toilet in the morning and sometimes I skip it. And sometimes I try after dinner and nothing happens. And again, we're notorious for, even if we feel an urge, we're too busy at that point in time and we don't want to stop what we're doing. Or especially I find with a lot of, it starts sometimes even really young ages, like middle school, high school girls, they don't want to poop at school. No. And then, maybe they go to college and they don't want to poop around anybody else and they're sharing a dorm room, and then they're working and they definitely don't want to poop at work because they share a bathroom with, 10 other colleagues, or they're in a job where they can't just easily leave and go to the bathroom on, the plant floor because the bathroom is a mile that way on the other side of the plant. So we tend to ignore that signal a lot. And what happens is it sometimes doesn't come back that day, right? You may have had that happen where you kind of I thought I had to go, but then I kind of finished what I was doing and I don't feel like I got to go anymore. So oh, well, and it just doesn't happen that day. We cannot just keep ignoring those urges. Okay. That regularity is really key from a behavioral standpoint. Exercise, water, fiber. So yeah, that cracked me up when I found that picture, when you're too busy and you finally have time to poop and you've been holding it forever. And she's going, it's been 84 years. Sometimes, yeah, then that's how people end up going days at a time, because they just miss that window, they ignore it. And then that opportunity, that urge never comes back. And they're just well, maybe tomorrow. Mm-hmm. Here's our positioning, right? We talked about knees above the hips. There are all sorts of fancy schmancy things that you can buy for underneath your stool that match your wood floors and clear plastic. And some of them are very artsy looking and stuff. I have my stool that my kids used to brush their teeth with. They don't need it anymore. So I confiscated it. So they have things that's a squatty potty on the left, but again, they do make other foldable ones, things like that. I've had people just start with something easy at home, start with a couple books, see how much height you like, because they do come in different heights and depending on the height of your toilet and the height of you, right? If a 5-foot woman gets on a super high toilet, she may need a super high stool versus a woman that's 5'6" and her toilet isn't that tall. She may need just a couple inches. So they do come in different heights, different styles. Fiber is so key for bowel health. You have got to be getting your fiber in, and almost nobody does. I mean, those are really high statistics. Over 90% of people are not getting their daily recommended fiber. Okay. And it's 25 to 35 grams a day on average, depending on your age and your bowels needs. Is a little different for everybody, but we're not getting it. And even if you eat super healthy, even when I was doing this, I thought, I'm just going to track a couple of my days and write down what I eat. I didn't even come close. But I know that about myself, but just for funsies, I did it again, because every once in a while I'll track a couple days. I have taken a fiber supplement every day for 15, 16 years without fail. I can't eat enough food in a day to get that. So even if somebody's eating super healthy, a lot of times they're just not able to get it all in. And odds are most of us aren't eating super healthy. Our diets are too high in sugar. We have processed foods, right? We are not getting that fiber that we used to, 100 years ago with our parents, grandparents, things like that. They ate differently than we do. So fiber, there are definitely different types of fiber. Soluble is the type that's going to dissolve and be like a gel. Okay, that's going to be like a Metamucil kind of thing. If you've ever had that, where you mix it up and you do have to kind of chug it because it gels, right? You can't just sip it because it'll kind of get that gel-like consistency. The insoluble is stuff that doesn't dissolve. So some people have figured out stuff comes out the other end whole, almost like peas, corns, carrots, things like that, that your body doesn't process real well. That type of fiber, still super helpful. We need both. But there are different kinds. But basically, fiber brings everybody to the middle. So people who are constipated and people who have diarrhea, y'all are getting fiber. Everybody needs that fiber, because fiber is going to help gel things together. So if it's too liquidy, too loose, it's going to help give it a little bit more form and keep it together. And if it's pellets, it's going to keep more water into it, which makes it softer. So it brings everybody to the middle, and it just makes it nice and soft and formed, but it's how much you need that we have to play around with, and what kind do you need? All right. I did put a couple different lists of fiber stuff in here. This stuff is really easy to find online if you're Googling fiber in foods, but I did list it because I think you guys have access to the the presentation here, so you could look at it. But here's the takeaway on some of all those fiber lists is people are always like, okay, well, where am I going to get the most, bang for my buck? Where am I going to get the most out of? Fruit, raspberries are huge. Raspberries were on sale for $1 a carton last week at Meijer's. I went and bought 10. because they're never $1, right? And of course, they're like one of the most expensive fruits. So unfortunately, some of the really high fiber stuff isn't necessarily the cheapest either, right? And when you're talking about people living on a budget or families with 2, 3, 4 kids that are just eating like pasta every night for dinner and getting no fiber, like this is a problem, right? Affordability of some of these foods. So fruit, avocado is up there too, pears, blueberries, apples with the skin. Okay, so if you're peeling it, you're not really, you kind of got rid of most of that fiber. Lots of beans. Beans are lovely too because they have a protein bonus. So not only do you get fiber, but you get protein, which is, so my freshman that's in college right now, that's when I took her to Meijer's and taught her how to grocery shop and look for like what's a good price and what's not. And I was like, okay, you need to figure out how you're going to afford protein and the fiber stuff. So I was like throwing a bunch of baked beans in her cart and I was like, here, so get your protein, some eggs and stuff. So beans are good. You kind of get a little bit of that bonus of protein too, which is nice. Okay. Canned pumpkin, lovely. Baked potato, but you got to eat the skin, right? It's all that skin stuff. There's a easy little recipe too that can help with some fiber intake. So applesauce, oat bran, prune juice, and you just mix it up and then you can eat a couple tablespoons of that. If you like that, that one's a little oddly textured for me. So I'm a texture person. So sometimes not everybody loves that one, but there's all sorts of chia seed recipes too that are actually really yummy. So if you're a Pinterest girl or a guy, get on there and look up chia seed recipes and you can make, they're almost like overnight. You can do overnight oats with some chia seeds and you can make it like add some cocoa powder and some fruit. And there's all sorts of different ways that you can start to get a little bit of extra fiber, but chia seeds and ground flaxseed is an awesome way of adding extra fiber to foods you're already eating. So if you're already eating an applesauce every day or a yogurt or scrambled eggs or anything like that, it doesn't change the flavor of it. So if you've got some ground flaxseed, sprinkle it into your mashed potatoes, put it in your yogurt, put it in your oatmeal, and you're going to get a lot of extra fiber just by doing that. Probiotics and prebiotics, there is a difference. Okay. So the probiotic is the bacteria itself. So you're going to get it from certain yogurts, fermented foods like kimchi, which I discovered the last couple of years. As long as it's not super spicy, I can eat it. Kimchi, sauerkraut, kombucha, which is a drink. The prebiotics are the food for the bacteria. So you could be taking a bunch of fiber, but if you don't have the bacteria in your gut to begin with, fiber may not be as helpful for you. There's nothing to feed. Or somebody may be taking all of these probiotics and they're putting all this bacteria in there and then they're eating high sugar, high fat diet and getting no fiber. You might as well just burn your bottle of, probiotics because you're putting it in there, but you're not feeding it and it's probably dying. Like you have to have both. You have to have the good bugs in there and you have to feed them, right? So it's got to be that balance. So cutting down on sugar and fats, those usually feed the bacteria we don't want overgrowing in there, like yeast, things like that. We want to feed the good stuff, okay? And sugar and fat does not feed the good stuff. It feeds the stuff we don't want to be overgrowing in there. So cutting back on that can usually really help. And then again, just some of the research on links to other thing with that biome. Okay, so what if feeling good seems like a stretch, but it just starts with better? And I always like that. Feeling good is the new looking good, right? If we feel good on the inside, don't we just like the whole day is brighter, right? Like if you just feel good inside. And so even if you're not 100% perfect, if you can help somebody feel 50% better, 70% better, right? I may not completely be able to 100% make you symptom free for life, but if it's a significant change, that changes quality of life, right? If somebody's not worried about leaking in the community anymore and they're not avoiding their church groups and their bus trips and travel and going to the park with their kids or grandkids or taking those walks with friends, because what if there's not a bathroom there and I really want to go on this trip, but my bowels and that makes me nervous. Like women and men start to avoid community stuff and that affects our health, right? Because we need that contact. And so even if we helped somebody not 100%, like it just got you better, like better enough that you're not afraid to go out and live life and be avoiding some of these things, like I don't want to go to a Broadway play because what if I can't sit through, the whole first act before the intermission? And what if I don't make it to the bathroom in intermission? And people do start avoiding things because bowel and bladder symptom. So talk to your doctors, right? Like, don't be afraid to say something. There is help out there. And if they're not asking you about your bowel, bladder health at your annual visits, then you need to bring it up if there's issues. Because they're just generally not asking, right? They're looking in their eyes and ears, and they're listening to your heart and everything. But they're not asking you like, hey, how's your bowel health? And maybe some people are, hallelujah. But a lot of times they're not asking about that. How often are you pooping? What does it look like? Are you straining? Do we have any concerns there? So make sure you're talking to your providers and understanding that there is conservative treatment out there. It's not always surgical, right? I think people think just because they're leaking, like, I don't want to go in because I don't want surgery. I don't want you to have surgery either. Like, that's what we're trying to prevent. I want you to not have it. And then worst case scenario, if somebody needs surgery, your outcome after surgery is going to be so much better because you will not be straining. You will have good bowel health. You have rehabbed your pelvic floor to support what they did surgically. So if somebody has a prolapse surgery and their pelvic floor is still weak as a kitten, odds are 5-10 years down the road, that surgery is going to start to drop because nothing's supporting it. Right? So post-op stuff too, people just do so much better by dealing with those things ahead of time. Okay. Like even some of the constipation stuff, I'll see patients all the time that have gone in and had, hemorrhoid removal and, Botox and the sphincterotomy, where they cut it and, and they were never sent to therapy beforehand. Why? Why would we not try this first before you go in and start doing surgical interventions for something that we might be able to prevent? And even if we can't prevent it, your outcome's probably going to be better, because then I still end up seeing them because they're still in all this pain after surgery. So food for thought, right? All right. I know I put this on here a couple of years ago, but I can't find anything that's funnier than this. And it cracks me up. So you got Kleenex on the bottom saying, yep, that's my job. Can't think of anything more humiliating. I'm so ashamed. By the way, what do? I'm the toilet paper, by the way, in this scenario, because this is my life right here for the last, 15, 16 years is, I meet somebody and it's like, oh, what do? I'm like, I'm a physical therapist. Where do you work? I'm like, oh, West Pavilion. Yeah, what do you do there? I'm like, pelvic floor, right? And then it's always like, hey, how about that World Series coming up? It's like they just like detour off the subject and because they don't know what to say about it, or they catch me later in the corner and they're like, hey, I have a question, So yeah, so it's always interesting when people find out what I do, but that always cracked me up. Okay, I love what I do. I want to help people. There's conservative care out there that's non-surgical. There's just some of these things are so easy to implement and change from a behavioral standpoint that makes such a significant difference. It's like people are just like blown. They sit in my office and they're like, that's it. That's all I had to change. Like, this was so simple. I'm like, I know. Right. But you don't know what you don't know. So until you know that there's stuff that can be done for it, then we just kind of deal with it and we think, oh, well, I guess I had 2 kids. I had 4 kids, or, I've had some surgeries, or guess this is just the way it is. But I say, don't put up with it. I say, ask for help and get it. Because, worst case scenario, maybe helps a little bit. Best case helps a lot. Right. Okay. So I know that's a lot of information all at once and your brains are like, whew. So questions, how are we doing on time, by the way? Oh, we're doing good. Okay.
Doing well for time.
We have
Awesome.
about 13 minutes left, and we have a couple questions.
Yes, I totally will. Let's go back there. Yeah.
Okay, anybody have a question in the question?
This is always one of those topics too. People are like, I don't know that I want to ask this out loud because they're going to think it's me. Right? It's okay if you start with, I have a friend. I have a friend who has a thing.
Could you show us the right way to do the Kegel exercise?
I can, yeah. So there's the catch, right? The whole statistical verbal instruction. So I will verbally instruct. So the question for people at home was, can I instruct on how to correctly do the Kegel exercise? And you'll hear Kegel, pelvic floor exercise, every pelvic floor contraction, all means the same thing. We're sort of getting away from Kegel just because people hear Kegel, and if you don't know what it is, they're not really sure. I always tell people it sounds like a Danish pastry or something. Like, I'll have a tea and a Kegel, make it raspberry. So I know, right? So basically the correct way to do that pelvic floor contraction, the easiest way to describe it is if you were peeing your pants right now, how are you stopping that? What are you going to contract to help pull that up and in? And those muscles close everything all at once. They'll close the vaginal urethral opening, rectal opening, or for men, urethral, anal opening, right? So it's got this closure and a little lift to it to help support your organs. So if you're thinking about this, like sucking up through a straw, like a milkshake, kind of this like this close and lift, that's the motion that you're looking for. Okay. And again, if you wanted to do the functional stop test, like if you go home and you pee and you try to stop your stream and you were like, oh, I stopped it, I'm awesome, you found your pelvic floor. Or if it slowed down to a trickle, then you contracted correctly. Okay. But again, that test you're not supposed to do all the time, but it's essentially that I want to hold in gas. I want to stop that flow of urine. That's basically a Kegel contraction. Does that help? Does that answer it? Everybody's in here going, I'm trying. I'm trying. That's where everybody tries. And then I see people's eyes get laser beam focused and I'm like, oh, they're trying and they're trying and they're trying. Yeah. Did that help? A little bit? Yeah, that's where it comes into like, if we verbally instruct people, like they're like, I don't know, I think I am, I'm not sure. And depending on your strength. So we grade muscle strength on a 0 to 5 scale. 0 is nothing happens. Like I ask you to lift your arm, nothing moves. A 1 is a flicker, all the way up to like 5 is a super strong contraction. So for pelvic floor, we would get like super strong squish from all the walls and a suck up and in. I usually don't see those people unless they're pain patients. But that close and lift is what we're looking for. But if I'm weak and I'm sitting against gravity, I may not feel much happen. Maybe you need to be lying down, right? Maybe you need to be lying down with pillows under your butt so that we have your pelvis lifted and gravity is sucking everything up inside. So depending on the strength, depends on what position you actually should be exercising those muscles in. So sometimes that's where that sensation comes into play, where they're laying down and they're contracting and they're like, yeah, I feel it. And then I'll say, okay, well, let's try some in sitting. And they're like, yeah, I don't feel anything anymore. Like it's just, or I lose it after 2 seconds, it's gone. It's like, okay, then you need to start exercising laying down and then build up to sitting eventually. Or when we start to progress people to standing, standing's a big jump. Even though our body's in the same plane, we go from support of whatever surface we're sitting on to nothing. Gravity's just sucking everything down. So in standing, I got to really fight that. So sometimes in standing, that transition from sit to stand, people stand up and they're like, yeah, gosh, it just feels so much weaker up here. It's like, yeah, because it's so much harder. So it depends on the position you're into. So don't fret if you were sitting here trying to contract and you're like, I don't think I felt anything. Go home and try it laying down. You might feel a little bit better there depending on what strength you are to start with. So that matters too. Okay. So yeah, it's essentially that if you were peeing, how would you stop it? Or my favorite other analogy is you're in a crowded elevator and you have to fart. How are you holding that in? Like you got to contract and squeeze. And that usually makes people go, whoop, and they kind of get it. So other questions?
Any other questions here in the classroom? Then I'll ask Susan, do we have any online?
I'm very proud of myself for being contained in my space too. I'm a mover and I'm usually like all over the place. So
I have a comment and I'll Jennifer figure out how to summarize this for the folks at home. I first met Jennifer about 3 years ago, I guess. And I enough issues that it was really interfering with my life. Told me right off the bat, there are no silver bullets, and she was right. But she taught me how to do some exercises, and I built into my day. And she blocked that about 10, 15 years. That's a big win for me. How do you summarize that?
I think, yeah, you just reinforced probably what I touched on earlier, right? Like any help is good help. Being able to get through everyday life with more ease, whether it's bladder control, bowel health, not having to worry about going out in the community and get halfway through your Meyer visit. And now you got to poop because you didn't feel like you had to poop before you left. You know, so it's just, having that bowel bladder health is just so freeing. Like it just, I don't know how to explain it sometimes for people. It's just like this weight is lifted that you're just not afraid to go do stuff. And that shouldn't be affecting your decision to go do something, right? To always have to take into consideration bowel bladder function when you want to go out and do something. it's not fun. Like, that's just not a fun way to start, living life and making decisions based off of what these two systems are doing for you when you could help it. And then just have ease of everyday life and just not even think to grab the car keys and go meet some friends to hike in the woods. It's like, and not worry about there being a bathroom or not, right? Or being able to travel with your friends or just sit through a movie without getting up, being able to sit through church without getting up. So again, it comes back to some goals. Like what's your goal? What do you want to be able to do?
Jennifer,
Yes,
can you hear me on the loudspeaker?
I can.
Okay, great. I have a couple questions in chat I wanted to get addressed. We have one that asks clockwise circle. I think it might be massage,
Mhm,
but rising on the left side of the body. Or wait, clockwise circle massage rising on the left side or the right side of the body. That's a question.
Okay, yep. So once you go around the small intestine, you got to start at the beginning of the large intestine, which starts in the right low belly.
Okay.
And then I know they told me not to go too far because then I'm off camera and the people at home can't see. I'll demonstrate both. Let me demonstrate for camera and then I'll step aside. So the right lower abdominal area is where the large intestine is going to start. So that's where you start that massage and then you work your way over and down the left side. And then, so for those of you that are here, I know I'm blocked over here, but that lower right abdomen is where you would start working up towards that rib cage, around the top of that belly, down that left side, just to the inside of that pelvis bone and into that left low belly. And then it disappears and does its little turn. So so starting lower right, moving up and around down the left side, and you should end in that lower left belly. That should answer that question.
Great. Three more questions. One is how do prescriptions like Flomax help the incontinence for men versus exercise?
So the Flomax is typically going to help you pee better. So with, and I could give a whole lecture on prostate. So the prostate sits at the neck of the bladder and it gives that urethra some support. And the unfortunate thing for prostate enlargement is it usually enlarges inward first before outward. And it starts constricting that urethra. So then you're not generating a strong stream, or you might have difficulty starting a stream or keeping a stream, or just not feeling like you're emptying real well. Men might start using the bathroom a little bit more frequently because they're not getting a good empty. So there's just more left over in there when their stream decides it's done and to stop. So the Flomax usually helps with the emptying. So it's going to give a little bit better contraction for the bladder wall, give it a little bit more force to kind of help that stream. There are other bladder medications that help calm the urge down and calm the bladder wall down so that it's not just contracting all the time. Because sometimes that there can be this, again, the bladder misfires sometimes. And if I'm just standing here minding my own business and I don't even feel an urge and all of a sudden my bladder just decides to go. So there are medications that sometimes we need to use in conjunction with therapy to help calm down that neurological misfiring of the bladder if we're not getting at it without it. And then that's just me communicating with the physicians like, hey, this is where we're at. This is what's happening. Do you think maybe you'd consider a prescription for X, Y, and Z to help with these symptoms, either short term, something like that?
Great.
Answer that.
Thank you.
Okay, we have one in here.
doesn't-
So let me hold on 1 second because she's been very patient with her hand up.
Is there anything in parental upbringing of children that affects the way that they address these things in their life?
Oh my gosh. So the question was about how as parents do we affect the bowel bladder health of our children, right? That's big actually. Right? It's how open was somebody in a household talking about correct anatomical terms with kids. I see West Michigan, I'm sure you guys are not new here, but we tend to be a little bit more conservative in West Michigan compared maybe to the other areas that I have lived. And it is interesting when I do travel and I'm at conferences or I help TA for our rehab institute. And talking with other people that live in other areas of the country, they just sit there and like, they're amazed at some of our stories because they don't encounter some of the things that we do frequently, as far as maybe lack of knowledge about their own bodies and anatomy. Like I see women all the time into their 20s and stuff that they don't even know that they have 3 openings. Like they think they have to take a tampon out to pee. And it's like, that's a totally different tube. So like lack of education. I don't know if it starts in the home or they're not getting it, wherever, they're not getting it along the way from physicians. They don't understand their own anatomy. Maybe it was something that you never talked about in your house. Like my kids are, my poor kids sometimes, but yeah, like there is no holds barred in my house. Like from day one, it's like, no, we call it anatomically what it is. This is your shoulder. This is your nose. That is a vagina. That is an anus. Like that is what it is. And so we're just very open with like, if they need to talk to me about something, they know that they can talk to me. So yes, upbringing can have a lot to do with it. I do see a lot of younger women too with a lot of pain issues. Just again, because I think just lack of awareness of that area of their body, how they were raised to maybe think about that space in their body as being very off limits. And again, I'm not judging one way or the other. It's just how somebody might have been raised. Let's just say without going into a ton of detail, but yes, it can definitely impact their thoughts and behavior around bowel and bladder and sexual health, for sure. Yeah. So again, if you're not comfortable talking with your kids or grandkids, it's like, I would always encourage people to just say, that is not my expertise. I'm not comfortable with that. When we have your annual checkup with your physician or your pediatrician, let's make sure that they know that they are there to answer those questions and that they've at least got somebody that they can talk to about those things. Yeah, because they're not getting the good information from friends, right? That's not happening.
I'm going to try to talk into Jennifer's microphone so
Ah.
that they can hear me at home. It is 11 o'clock, so I think we need to bring things to an end. Thank you, Jennifer, so much. This has been a wonderful presentation.
Thank you.
And I have a concluding question. Is Michigan still an open access state? Can we get an appointment with you without our physician referring us?
Yes. Oh gosh, thank you for saying that. That was a super good question. So yeah, Michigan is a direct access state. However, your insurance still dictates that. So you could walk in off the street and make an appointment to physical therapy for neck pain, knee pain, pelvic floor, whatever. But your insurance company usually says, no, you still need a prescription from a physician or we're not covering it. But that doesn't mean that your physician actually needs to physically see you, right? If you call up your doc and it's like, hey, I went to this presentation thing and like, it sounds kind of interesting and I have this issue, can you just put a referral in? And a lot of times they will. I mean, unless it's something they really feel like they need to see you for, but usually they'll just put a referral in the system and then insurance is happy and, everything gets covered. Sometimes you have X amount of visits per year of physical therapy total. I am not considered a specialty as far as billing goes. It's physical therapy. So it's not a specialist. So if you're looking at your insurance stuff, it's not a specialist copay or anything like that. It's just PT. Some people have X amount of visits per diagnoses. Some people get X amount of time per diagnoses. So everybody's insurance is different. Some people you have 60 days per diagnosis and you're done. I don't care if you're good or not, they cut it off. Other people it's visits per year, stuff like that. But yeah, we are direct access, but insurance usually still wants you to have a prescription.
Thank you very much.
Good.
Y'all have a good day.
Thank you so much for having me. I appreciate it.
Thank you.
Thank you.
Bye, everybody at home. I'm going to go ahead and close the class.
So we don't